Hi, this is Dr. Bernstein with your April 2018 teleseminar. Before we start, I want to give you our usual warning that my answers to these questions are generic answers, not necessarily keyed to the individual, because I have not examined the questioner or the patient. I have not gotten a full history. It's very hard to have a perfect answer. So I'm giving a general answer that may or may not apply, but will be educational for the entire group of listeners. So just remember that I could be totally wrong in the answer I give to you. Today we're going to have a special subject because I've had many questions both by email and for our teleseminar from parents of small children who are complaining that since they put them on a low carbohydrate diet, they're showing ketones in their urine. Well, the first point is that ketones are not harmful, but they are a sign of something. What's harmful is high blood sugars, but kids don't have much of a blood sugar reserve in terms of glycogen stores. They can use up their stored glycogen very rapidly. So if they're on a low carbohydrate diet and they're physically active, they're going to use up a lot of stored glycogen, which becomes glucose as they need it, and they need a backup supply. The backup supply is protein. And in the case of patients that I've actually seen, in every one of these cases, the parents have been giving the kid inadequate amounts of protein. In fact, the kids usually have not been growing when they come here for the first visit. We normalize their blood sugars, and we give them much more protein than they had been getting before. Maybe triple, quadruple, 5 times as much as the parents had been giving them. There are these myths on the internet that you should give people a lot of fat, and I maintain that whatever fat comes with the protein, that's the fat that you get. What you need is the protein. You do need some essential fatty acids, but they come with the protein foods. So I cannot overemphasize the need for protein, no matter what sort of diet you're on if you're a child. But certainly if you're on a low carbohydrate diet, you're going to need it as a source of glucose. In fact, I think the very earliest paper that I got published, it was long before I became a physician, was an abstract of a talk that I gave at a medical conference, a diabetes conference, and it was published in Acta Pediatrica Belgique, a Belgian publication, and the title was Protein as the Principal Source of Glucose in the Treatment of Diabetes. And that sort of sums it up. Gluconeogenesis is a chemical process by which the body converts protein to glucose as needed. So instead of loading the patient with carbohydrate that rapidly raises blood sugar and cannot be controlled by insulin, by injected insulin, because the rise is so great, you give protein and it gets converted to glucose as needed. And you could cover it with small doses of insulin. Our first question. I have lower extremity neuropathy that started with numbness and has now progressed to coldness. I'm 65, my body mass index is 31, which is elevated, so he's a bit obese. Never had diabetes. A1C is 5.5, which is an average blood sugar of about 120. So I would call it mild diabetes. and I have no other medical problems. Nerve conduction studies show definite neuropathy, and the neurologist said it was diabetic. So he's wondering why will weight loss relieve his neuropathy? Well, there are several theories that I could think of as to why he has neuropathy. One could be that for years he's had an elevated A1C, and he only got it down with a low carbohydrate diet perhaps recently, and that could have caused neuropathy. Or he could have had a deficiency syndrome. He could have been deficient in one of many vitamins that can cause neuropathy if you don't get enough of them. He might have poor circulation causing impaired sensation. So someone should check his ankle brachial index, which is the blood pressure in the ankle versus the blood pressure in the arm, and that will tell if he has poor circulation in his feet, which can present with numbness and coldness. Next question. I've been a diabetic 50 years, that's a real survivor, with really no secondary complications. Well, I've not seen any diabetic of 5 years who is without complications. He's just not been properly examined. My eye doc says he can hardly tell I have diabetes, but I have never had stable good blood sugars. Am I really in good condition? Well, the mere fact that you're alive after 50 years of diabetes is amazing. So you're certainly in good enough condition to be alive. And if I were examining you, I tell every new patient that I'll find at least 15 to 20 complications of diabetes when I examine you. The diabetes part of my physical exam is 8 pages long. I'm a type 1 and have problems with protein foods. Every time I eat a meal with mostly protein, 6 to 9 ounces per meal, well, right off the bat, he's stating a problem. He's varying what he eats at his meals, I think. And if you're trying to control blood sugars, you have to have pretty consistent meals from one day to the next. And the difference between 6 and 9 ounces is considerable. And a low amount of vegetables, as you recommend. I am forced to inject additional rapid-acting insulin at about 2 hours and 45 minutes, and again at 4 hours after the end of the meal, in order to keep the blood sugar level. I use Humalog. Why does this happen? It happens probably because you use Humalog. Humalog is too rapid for protein, and it doesn't last long enough. So it can send you initially too low, and then when it stops working a few hours later, you could go too high. So you should read my book, Diabetes Solution, and do what it says there, which is to use regular insulin for meals. Regular insulin is slower acting, and the other thing that it teaches you is to have consistent meals, day after day, the same thing. If you get tired of it after a few months, you change what you have, but again, day after day, the same thing, unless you want to have different insulin doses every time you eat, which is pretty difficult. You never can calculate properly. It has to be by trial and error. My baby boy was diagnosed with diabetes type 1 this November. Doctors have advised me to give up breastfeeding as soon as possible, but it isn't as easy as one might think. Would it be that we both go on your diet and we stop breastfeeding feeding as soon as possible. Absolutely. I wouldn't say this if he were not diabetic, but breast milk is loaded with glucose and will send his blood sugar sky high. And there's no way by injecting insulin that you could prevent this, because the glucose works so fast, and injected insulin would have to be given intravenously to work fast enough to cover it. Medjool dates, should I avoid them to lower blood sugar and prevent diabetes? Any dates are very high in carbohydrate, rapid-acting carbohydrate, and if you avoid them, will it stop you from getting diabetes? I don't know. Will it cause diabetes? I don't know. I think that it's you're talking about what's called the paragenetic phenomenon. Your genes may predispose you or not predispose you, and the environment also plays a role. So I'd say they stay away from them, but it's a matter of trial and error and individual variation. I'm a Vietnam vet exposed to Agent Orange. I'm a type 1 diabetic using insulin. I plan on following your diet plan in the very near future. Because of my exposure to Agent Orange, are there any other things that I should be aware of? Not that I know of, but I'm not an expert on Agent Orange. I would say that if you're a type 1 diabetic, you should read my book and do what it says right away. Type 1, I suffered quite dramatic drops in blood glucose immediately upon starting exercise. I find sustained exercise has much less dramatic effects than the initial large drop. It has always made me very anxious since my high carb days. Could this anxiety be a factor? Well, I doubt that anxiety is going to cause a blood sugar drop. Usually, in my experience with myself and with patients, it would cause a blood sugar elevation. Now, one thing that might affect your rapid blood sugar, your blood sugar drop upon starting exercise could be the proximity of a meal. If you had a meal shortly before exercise and took insulin to cover the meal, and then you start the exercise, you can stop your digestion cold. Exercise stops digestion. And then you get hypoglycemia because you took the insulin for the meal, but you're not digesting it. That's a possibility. Next question. It seems every time I put on a new Omnipod insulin pump, my insulin requirements change. No consistency. Do you think this is an absorption or pump problem? I warn about this in the book. I've warned about it on my teleseminars over and over. Pump users eventually develop scar tissue at the needle site or the pump tubing site, and that scar tissue prevents predictable absorption of insulin. So you get inconsistent absorption. It's inevitable with long-term pump therapy. Some people can get away with the scar tissue for the first year or so, but eventually it comes and is a real problem. Is it better to take 1 milligram of glimepiride, that's sulfonylurea, and target an A1C of 5, or not take the glimepiride and then the A1C is about 6.2. Again, I'd suggest you read my book, Diabetes Solution. Glimepiride is a sulfonylurea. The sulfonylureas have been shown to have adverse cardiac effects and also have been associated with hypoglycemia, but I'm more concerned with the cardiac effects. You might be better off with metformin, or I should say glucophage, or Avandia, or even a combination of glucophage and Avandia. Even the possibility of insulin in order to avoid a sulfonylurea drug. But I don't recommend a higher hemoglobin A1C. That certainly would increase your risk of heart disease. What is your position with respect to seeds? For example, chia seeds, sesame seeds, etc. Well, I certainly include seeds on the list of acceptable vegetables, but I don't recommend them for snacking, especially if you're a type 1 diabetic, because for type 1s, anything that you eat has to be covered with insulin. So if you're snacking on seeds, you're going to have to take insulin, and if you'd have to measure exactly what weight of the seeds you were taking, and you'd have to be consistent, and it's not worth the effort. Type 2s who are very mild, those who are very mild might get away with snacking on seeds, but I'm not certain. There's also the remote possibility that if you're eating the shells of sharp shells of seeds, that you could irritate your intestines. What advice can you give to calibrate the Dexcom continuous glucose monitor? And this person goes on to detail the problems that are so common when you try to tell a continuous glucose monitor what your blood sugar is. The Dexcom usually has a reading that it's been getting from a sensor that has tiny fibers in your skin. And that sensor is not always right. It could be because it takes a half an hour about for the interstitial fluid to match your actual blood sugar. So if your blood sugar changes rapidly, the reading on the Dexcom meter could be incorrect. Now, what I find is if I give it, let's say that it says that my blood sugar is 96, and I find it's really 80. If I put in a number, it will usually average that number with the 96. And so I have to put in the same number a second time in order to get it to accept my reading. Part of the reason for this phenomenon is these things are programmed on the theory that most blood sugar meters are inaccurate and have a wide variation in their readings, so you better use your blood sugar meter twice and enter two different readings. Well, I happen to use a meter that's very accurate, the Freestyle Freedom, which is accurate as long as your blood sugars are under 120. All the meters are inaccurate when you get above 120. And of course, if you're reading my book, you don't have blood sugars above 120, except if there's an accident, if you do something by mistake. So one option is to just put in 2 readings and it'll then accept your reading. Another option is to double the difference between your reading and the reading on the Dexcom receiver. Let's say that my reading is 90 and the Dexcom receiver says 100. I'll double the difference of 10 and put in a reading of 80 and it'll come out 90. So that's the trick. You can double the difference or you can give 2 readings. I have read that 80% of type 1 diabetics still produce some level of insulin. If you lowered your sugar intake to match your insulin level, would you need medication? Well, 88% of type 1 diabetics may make some insulin, but it usually is not detectable by measuring C-peptide levels. It's usually discoverable on autopsy if they carefully study the pancreas that was removed and have it stained for insulin granules. You may find a few. So we're talking about a very small amount of insulin. There's no way that you can utilize that insulin to control your blood sugar if you're a type 1 diabetic. My 3-year-old daughter has type 2 diabetes as a result of me having gestational diabetes when I was pregnant. She is now on a low-carb diet and is not overweight, though she is on the cusp of being so. What treatment would you recommend for her? Her fasting levels are normal. Now, this parent says 4.5 millimoles per liter. I have to calculate that. 50 would be 90. So this kid is probably running as high as 80 fasting, might be a little lower. But what are her blood sugars after meals? Fasting levels have very little significance by way of information. It's the post-meal blood sugars that are of concern. Those are the highest blood sugars of the day. And it could well be that she may need injected insulin. She might get away with some oral hypoglycemic agents, but I'm sure they haven't been tested on small children, and therefore their safety might be questionable, but diluted insulin might be necessary. I am undergoing physical therapy for a pinched nerve. I am pre-diabetic with an A1C level of 5.2. That's an average blood sugar of about 108. After 3 weeks of physical therapy, they're recommending an oral steroid or injection. Should I proceed with this steroid treatment? Could steroids cause full-blown diabetes? Yes, they could cause full-blown diabetes. And I just advised my sister 2 hours ago, who has to receive an oral steroid for a special problem, that she should be getting metformin, in particular brand name glucophage, while she's getting the steroid to prevent her from getting diabetes. There is a fairly high incidence of diabetes after prolonged use of steroids, whether injected or oral. So I also suggest that you can consult a physiatrist, that's a doctor of physical medicine and rehabilitation medicine, to see whether you really need the steroid. But if you do really have to have a steroid, I would think that you also have to take metformin. same time. In particular, the brand, not the generic. Skeptics to low-carb eating for type 1 diabetes claims it is dangerous when you get hypoglycemia during the night because you have not stored glucose in the liver for the body to release and potentially save you from sinking deeper into hypoglycemia. Is there any truth in this theory? The hazard is with high carbohydrate diets where the blood sugars are far more variable. They go very high and they go very low. If you visit type 1 ONE GRIT, type ONE GRIT, G-R-I-T, on the internet, you'll see how many people, type 1s, are walking around with level blood sugars all day and all night on low carbohydrate diets. I might add that how does one build up glycogen in the liver? Most type 1s who have not read my book and are walking around with high and low blood sugars all the time have low glycogen stores because it requires 24 hours of normal blood sugars to rebuild full glycogen stores in the liver and also in the muscles. So you need normal blood sugars to build up glycogen, not high and low blood sugars as the high carb diets would give you. So someone has misinformed you. Do you have a support person in Perth, Australia? I'm sorry, the only person I know who has many physician contacts in Australia is Ron Raab, R-A-A-B, who's president of a company called Insulin for Life. So if you look on the internet at Insulin for Life, L-I-F-E, .org.au, you might be able to contact him, and he might know some physicians who support low-carb diets. I understand there are a few, but I don't know them personally. Next question. Dietary recommendations in Dr. Bernstein's book, Diabetes Solution, have a lot in common with ketogenic diet. Would Dr. Bernstein care to comment about similarities and differences? Well, first of all, there are many ketogenic diets. It's what what shall I call it? The initiator of the diet happens to call it. There are many ketogenic so-called ketogenic diets that are low in starches and high in fruit. Those diets are not for diabetics. There are ketogenic diets that are low in protein, very common, quite harmful. So I would say, and most of these people who make up a ketogenic diet are selling something. They're selling food, they're selling a book, more than a book. They're usually selling a system that you subscribe to. And they're not geared toward the well-being of patients, they're geared toward making money. So I would say that you have to be very careful when someone tries to sell you a ketogenic diet. And again, many of them have fruit, which is bad, raises blood sugar, or they have too little protein. I have familial partial lipodystrophy. Do you address this disease and its intimate link with diabetes and very high triglycerides anywhere online? No, I don't address it. It's a very rare condition. I don't know much about it. Occasionally, you'll read an article in the scientific literature about it, but one thing for sure is that people with this ailment should have very low dietary carbohydrate, because elevated blood sugar raises triglycerides, and high triglycerides can be very dangerous. They can cause pancreatitis and other problems. What kind of tests do you suggest in LADA, latent autoimmune diabetes of adults? As with other diabetes, the most important thing is blood sugar. You check your blood sugar levels. If you're interested in technical information, theoretical information, you could look at your post-meal C-peptide levels, and they're going to vary. And with your blood sugar, you have to check blood sugar at the same time you check C-peptide, and you can see how much insulin you might be making for a particular blood sugar level. But that's theoretical. It's not going to change your treatment. And I certainly recommend that you read my book, Diabetes Solution. Do you have any recommendations of protein drinks for the gym? I do not recommend protein drinks while you're working out in the gym. If the people who have most problems are type 1 diabetics like me, if I come to the gym with too low a blood sugar, my performance will suffer. I will not hit the performance level that I hit the prior week. If my blood sugar is high, well, I usually don't go in with a very high blood sugar, but I'll try to go in with a little bit above normal, maybe 90 or 95, because it's going to come down. Now, how do you treat the blood sugar as it comes down? Protein doesn't work fast enough. Having protein drinks will not do any good. You need pure glucose. So I use liquid glucose, and if I come down to 80, I'll try to get it back up to 90 as rapidly as I can. Now, there's another situation with relation to going to the gym that does require protein, and that is muscle building. If you're exercising and trying to build muscle, you're going to need much more protein than if you're not in your diet than if you're not exercising. And that protein can be any form of protein. It could be fish, it could be meat, it could be eggs, it could be protein drinks. It's a matter of what your preference is. If they're protein drinks, you don't want them with a lot of added carbohydrate. You want with close to zero carbohydrate in the drinks. And you don't want a soy protein drink, because the soy will act as like a female sex hormone. So whey protein is good and egg protein is good. So you can use whey protein drinks or egg protein drinks. Another clarification that I've made before on these seminars is that there's only one state that I know of in the USA where protein drinks, the content of protein drinks is regulated. There are no, and that's California. They don't allow added hormones or impurities, et cetera, et cetera. You won't find pieces of insects or rodents if you're getting protein powder from California, hopefully. So that's about all I can say about protein drinks. I'm a 60-year-old male, diagnosed type 1 in 2008, and have been following your program for 2 years. My GP in Australia is low carb and referred me for a CT coronary calcium score. And what's happened is his score has gone up from around 200 to around 400 over the course of a year. And he's asking why. And what I'm speculating is that, and he could check this with a radiologist who examined the images and applied the program that calculates the score. The score is not a precise number that is going to be the same every time you do a radiogram. So my guess is that if you were to do a calcium score 2 days in a row, that you'd get slightly different numbers, which is what happened here. 200 to 400 is close enough that I'm willing to bet that's within the normal day-to-day variation. But I'm not certain. So you have to contact the radiologist. You also might want to know what's happened to your blood sugars in the past year and what's happened to your A1C. If you started off with a very high A1C and came down to a high but lesser A1C, you're still damaging your arteries. 67-year-old female. One of my exercise routines is to swim for 1 hour at a moderately demanding pace. I give my daily Lantus 10 units at 12 noon. Now, right off the bat, that's a potential problem because one shot of Lantus a day is usually not enough to cover 24 hours. I give my pre-swim Novolog 4 units at 7:30 a.m. Now, why she takes Novolog to cover her swim, I don't know. That's a rapid-acting insulin. Some days my BG drops 100 during the swim. Other days it stays constant. Other days it goes up by as much as 70. I have not yet identified the reason for the difference, which may be pre-swim meals or how strenuously I exercise. So, right off the bat, she's giving us clues, and certainly pre-swim meals, and I'm willing to bet, I know for sure that she's not using the regimen we recommend in the book, and therefore she's probably following a high carbohydrate diet, getting high and low blood sugars frequently, and just because they're high and low after the swim doesn't mean that it's strange. It's probably high and low all day long. She's asking, is she risking ketoacidosis on the days her blood sugars go to 270? Well, it depends how long they stay at 270. If you rapidly get it down, I doubt that you'll develop ketoacidosis. Could being insulin resistant and pre-diabetic cause ringing in the ears? Not that I know of. You could search the internet for the myriad causes of ringing in the ears, and there are quite a number of them, including, I might add, vitamin deficiencies. I've read so much about how bad insulin is for you. I've been taking Humalog most of my life. Is it worse to allow your blood sugar to remain high or take sufficient insulin to bring it down? My doctor wants my A1C to be close to 7, but I'm hearing it should be about 5.3, with blood sugar levels 80 to 90, which is correct. Well, I suggest you read my book, Diabetes Solution. I don't know what's bad about insulin. If you're eating a lot of carbohydrate and taking a lot of insulin to cover the carbohydrate, you're going to get fat and you're going to have erratic blood sugars. But if you follow my book and have very little carbohydrate and it's slow-acting carbohydrate, you can take insulin to cover your meals and have level blood sugars, and that's what the game plan should be. And they should be normal. If you're an adult, we like 83 because that in populations corresponds to the lowest mortality. I'm a type 2 diabetic on a low-carb diet, but I'm losing weight, muscle mass rapidly. I'm struggling to understand my required protein intake. Most articles suggest about 1 gram per kilogram of body weight, which for me would be 60 grams or 2 ounces. Well, the way I calculate it, I get 10 ounces. So you've lowered your protein dangerously, and I would suggest that 60 grams of protein a day, there's 6 ounces of protein, there's 6 grams of protein per ounce of protein food on average. So if you had 60, if you needed 60 grams of protein, you'd need 10 ounces. 6 times 10 is 60. You may even need more than 10 ounces if you're losing muscle mass. Again, you should read my book. My 11-year-old daughter was diagnosed 3 weeks ago with type 1 diabetes. I immediately implemented a low-carb diet, and she's down from 4 shots a day to 1 to 2. Her blood sugar has been in the normal range for the last week and a half with very little insulin. What's the best way to work with her doctors who don't support a low-carb regimen? Well, I've said this over and over, but because it's so important, I'll say it again. You have to find a kindly pediatrician who's intelligent, who will understand basic science and logic. We've found we usually get complaints from patients who have endocrinologists who tend to be afraid to violate the guidelines of the American Diabetes Association. So they're afraid they're going to be sued for malpractice if they violate the ADA guidelines, which recommend high carbohydrate. So you have to find someone kindly and intelligent, probably a pediatrician, not an endocrinologist. My wife has type 1 diabetes. Your book says that sugar level shouldn't go above 90 to 126 milligrams per deciliter. But our doctors in Europe, Lithuania, are telling that this is normal after meals. Even 180 is also normal. Well, that's not so. Just because what they're saying is it's normal for diabetics who are uncontrolled, and which is true of most type 1 diabetics around the world. Just because it's common doesn't mean that it's normal. if you looked at our ancient ancestors before the development of agriculture, they only ate protein foods, very little carbohydrate, and then it was slow-acting carbohydrate. They couldn't get blood sugars of 180 or even 100. They probably remained level at around 80 all the time. 26-year-old type 1 female, do you have any recommendations for planning pregnancy? Yes, very important. You must have absolutely normal blood sugars for 3 months prior to conception. I've seen patients who did not heed this warning, and they had very dire consequences during their pregnancies. That's basically it. You have to have normal blood sugars for 3 months prior to conception and thereafter throughout pregnancy. Why not eat more vegetables and cover them with Humalog? That's fast-acting insulin. They have low enough glycemic index, and Humalog has the potency to cover the extra carbs. Yeah, it's very potent, but how do you get it to act in a predictable fashion? It's very rapid acting, and if you have a lot of carbohydrate, you're going to have a big peak in blood sugar. The Humalog gives a big decline, sharp decline in blood sugar. How are you going to match the up peak with the down peak precisely? You don't even know the shapes of the peaks. Whereas if you have a slow, gradual increase and a slow, gradual decline, as with regular insulin in small amounts, you could more or less match the decline with the peak. Whereas if you have sharp increase and a sharp decline, you never get them right. Try it and you'll see. Does Dr. Bernstein get high blood sugars? How high, how often, and for what reasons? Dr. Bernstein gets high blood sugars when he makes a mistake. If he gave a shot with an insulin pen and it had a big leak, or if he ate something that he thought was benign and it wasn't. Now, I took some diet, what I thought was diet orange soda, a quart bottle. I actually bought a load of them. I had 4 bottles of diet orange. The 5th bottle was not diet, but it looked like the other 4. And I was drinking them at night and couldn't understand why my blood sugar was going to 200 and 300 3 nights in a row. I was pumping in insulin to bring it down, didn't know what was happening, was very worried. And then when I threw away the empty bottle, I saw that it was not diet. So these things happen. Here's a diet cream soda, root beer. Hopefully it was the right stuff. I would appreciate any suggestions for gaining weight. When I had my first A1C 3 years ago, it was 6.3. I read your book and went on your diet immediately. Unfortunately, I was too enthusiastic and lost 20 pounds. Have gained back 5 pounds, and now with 2,000 milligrams metformin per day and careful food, I have a 5.8 A1C. Well, that's not normal. I'm a 76-year-old woman who exercises a lot. My Kaiser doctor requires an A1C of 7 to use insulin. Well, you clearly need more protein to gain weight, and you probably need insulin. And it's insulin and protein that I repeatedly recommend for gaining weight. And I've had many complaints about Kaiser physicians. There are some Kaiser physicians that use common sense, but there are many who follow the Kaiser guidelines. So I'd suggest that you try to ask your neighbors if they know of a kindly family practice physician who will listen to logic. I'm a type 1, check my blood sugar every 2 hours, trying hard. I eat keto. Right away, I worry. My question is, dinner at 4 p.m., woke up, blood sugar was 79. Had decaffeinated tea and 2 hours later, 150. Why? I love all your info, and I'm trying to have blood sugars under 100 all day. Well, this person has not read my book, and he's eating keto, which may mean that he's eating a lot of fruit. So I would say that you read my book, you probably need basal insulin. Oh, he says he's a type 1. I have no idea what's going on. You can expect that if he's using standard treatments that he's going to have up and down uncontrolled blood sugars. Okay. My 6-year-old was diagnosed with type 1 10 months ago. He eats no more than 50 grams of carb a day. Wow. For a 6-year-old, that's a hell of a lot. Let's say that this 6-year-old weighs 50 pounds. He probably should not be getting more than about 15 grams of carbs a day. Is a BG of 61 harmful for my son at night? And if yes, how can I prevent it? Well, I would suggest that you read my book, Diabetes Solution, that you get a continuous glucose monitor to see what his blood sugars are at night, and 61 is not going to do harm, but it's low enough that he could be 40 or 30, and that you don't want, because that can be harmful if he gets convulsions. I am 37 years old from India, suffering from proteinuria. Blood pressure on average is 130 over 95, and the 95 is very high for systolic pressure. Sugar fasting was 83. Kindly suggest a good diet plan if possible. Well, a very low carbohydrate diet. Your fasting was 83, but what was it after meals? I again suggest you read my book, Diabetes Solution. I'm sorry that I've answered so many questions from people who have not read my book. I'll try to be more careful in the future. Next, I would like to know what makes a type 1 have itchy skin. Comes in different areas of my body. My A1C is 5.4 for the last couple of years. My guess is that you have psoriasis. Almost 100% of my diabetic patients have psoriasis, and psoriasis causes itching, and it can itch anywhere in the body, I've had psoriasis since I was 3 years old. And you'll see me scratching right now. I have an itch right in the back of my neck. I'm scratching all day long. Most commonly, my nose and my ears. Got a little itch over here. Just being reminded of it. Scalp itch is very common. If you have diabetes and dry feet, I suggest you lubricate your skin with coconut oil, but you also should lubricate your psoriatic lesions with coconut oil. Past year, my right elbow had an itchy scale, but putting coconut on has made the scale totally disappear. No more itching. It takes months of lubrication to do the job, but and you could read on the internet about psoriasis. You also can consult a dermatologist, because it could be that you don't have psoriasis. But that's my best guess. What is your opinion regarding the use of Afrezza inhaled insulin? Do you have recommendations regarding its use? Well, I can see the possibility for using it by severely insulin-resistant type 2 diabetics to bring down an elevated blood sugar. The big problem with Afrezza is that it's inhaled, and you don't know what your absorption is going to be from one dose to the next. It comes in cartridges of 4, 8, and 12 units. Again, indicating that even the manufacturer doesn't know what effect it's going to have on your blood sugar. Because if they did, they would give you 1 unit or half unit cartridges, so you could get fine tuning. But they're giving you such big doses because they don't know how much you're going to absorb. And it's the unpredictability that's the potential problem. But if you're very insulin resistant, the 4 unit dose might have very little effect on your blood sugar. So you might find that you can bring down your blood sugar after an elevation, or possibly use it to cover a low carbohydrate meal, because it's being added to the insulin that you're making yourself. And that's it's all hypothetical in my mind as to whether this can be of value in this situation, because I've not tried it. I had one type 2 patient who travels a lot and would use it on airplanes to cover meals, but he didn't get predictable results, so he stopped using it. I have some samples waiting for Samantha to come back, because I'm afraid to try it out experimentally on myself without someone competent with me to observe what's going on. So I don't mind experimenting on myself, but I need an observer. I tried to get the rep from the company that sells it to come and watch, but they would not do that. So they're worried about something. I see there is a new arm patch system where the test strip is held to the patch. Any info on its accuracy? You're probably talking about continuous glucose monitors. There are, I believe, 4 different ones on the market. You could look on the internet to see what you could learn about them. They're for type 1 diabetics, and I think for any type 1 diabetic who sleeps alone continuous glucose monitor is essential. But they're expensive. They are covered by insurance. However, Medicare, unfortunately, will not pay for the monitors that use a follower, that is another person who can see your blood sugar on their iPhone. And that's essential for children and for older adults. Older adults like me have to pay for this very expensive system. Cost me several $1,000s a year because Medicare will not pay for me to have a system that uses a follower, and I need a follower or want a follower. Is there a payoff at somewhere along the line? Very possibly. Type 1 diabetic, last A1C 4.7. An Oreo type cookie every 1/2 hour during moderate physical labor keeps my blood sugar flat. Why does the same cookie increase my blood sugar randomly between 10 and 40 points when I'm not doing physical labor, whereas the same amount of pure glucose predictably increases it by 15 points? Well, my guess is that you have gastroparesis. Certainly the digestion of the cookies is happening at different rates. That's my guess. I could be totally wrong. You can have your doctor do an RR study to see if you have autonomic neuropathy, and if you do, you have gastroparesis. I've been told I am pre-diabetic. My A1C is 5.8, which is an average blood sugar of 132. Please advise regarding a diet for pre-diabetes. Again, I would call you a mild diabetic. You're walking around with an average blood sugar of 132, probably goes up much higher after meals. I'd suggest you read my book, Diabetes Solution, and follow a very low carbohydrate diet. I take a lot of vitamin C. It seems to help, but your book says it can show false lows. Can you elaborate on that? What does it help? If you have scurvy, it might help. It doesn't show cause. It is a poison to the enzyme in blood sugar test strips that measure your blood sugar level. So if you take high doses of vitamin C, you cannot rely on your blood sugar readings. In fact, at very high doses, your reading will be 0. I once met a patient of Dr. Atkins who thought her diabetes was cured because her blood sugar was 0 when he gave her IV vitamin C. So I'd say stay away from it. If your religion mandates that you take vitamin C, I say take no more than 250 milligrams a day of time-release vitamins. Well, that's it for tonight. Thanks for listening. Our next teleseminar is going to be on Wednesday, May 30th